Welcome to Giants of Cardiothoracic Surgery and this interview with Dr. J. Donald Hill, legendary surgeon, researcher, mentor, inventor, businessman, and importantly, a super nice guy who was my department chairman for over 20 years. So I'll be referring to him somewhat informally as Don, without meaning any offense. My name is Jill Lay. I'm a senior editor for CTSNet, and I'm delighted to be here. Thank you so much, Don, for joining us today for this interview.
Thank you, Jill. Good morning. And it's an honor for me to be here. I'm happy to do it.
Good. You've been an incredible contributor to our specialty for decades. I'll just hit some of the highlights. You have over 300 publications, dozens of research grants, over 25 personal patents, including the aortic punch, which continues to be used about 300,000 times a year in the United States. You've been pursuing VAD technology for decades, including founding Thortec Labs. But I'd like to focus on some of your many firsts during your long career. After graduating from, is it Dalhousie University in
Dalhousie.
Dalhousie.
No, that's the Canadian way of spelling it, pronouncing it.
Thank you. Where you grew up, your interest in hockey continues to pursue you, as does your interest in mechanical device technology. That took you first to Sweden and then San Francisco, where we had the opportunity to work together. But you first worked with Frank Gerbode there. And I know he was a tremendous mentor to you, and you likewise have been a tremendous mentor to many physicians and nurses like myself over the decades. Did you learn to be such a great mentor from Dr. Gerbode? What kind of mentor was he?
Oh, he was a great mentor. He came out of the Second World War, and he had an interest in cardiac surgery, which was sort of just getting started at that time. And one of the early important things he recognized that it was a team therapy, that you, not only that, you had to have new kinds of equipment, postoperative care became an issue. And he early on recruited fellows from all over the world. And he also recruited full-time physiologists, John Osborne, and full-time engineers, Mr. Bramson, and that made for an important team. And those people were all treated very well on a kind of not a personal level, but at the level of being a fellow. You were, I would say, given what is generally called a graduated level of responsibility. Dr. Gerbode was not one who held your hand while you were doing things. I think one of his greatest things was that you learned to do things, and he didn't stand over your shoulder watching you do them. He just didn't show up, and therefore you had to do it. And in the operating room, you sort of started as an assistant, and then you helped him, and he demanded good assistance, and then you would end up being starting cases, finishing cases, and then eventually he wouldn't show up, and you did it all on your own. And he was not one that stood across the table and taught you how to do surgery. You learned, though, by watching him and sometimes him telling you. And in postoperative care, there's a huge amount of responsibility he delegated. The fellows and the director pretty well had free hand in making all the decisions and deciding everything. Occasionally you might call him about something, but mostly you learn to think on your feet, do things on yourself. And he gave everybody opportunities to do research, to get into the lab, to get the credit for it, to write the papers, have your name first, and so that you had a career when you finished. So he was a great leader, and he was sort of like, because of the war and etc., he was sort of like almost 2 generations ahead of most of the people that were trainees. And so we held him in high regard, but he gave us a lot of leeway.
Well, you
So
certainly
I was very lucky.
I consider myself very lucky to be mentored by you. So his skills definitely transferred to those that he worked with. Some of his research was incredibly groundbreaking, and you were part of that. One of your firsts in 1971, your oxygenator research with Dr. Gerbode and others led you to publish the first successful use of a prolonged mechanical support run using ECMO for 75 hours in a 24-year-old man with shock lung. What do you remember about that case and how it unfolded?
Well, it was a really exciting time, and part of the background was that I came there in 64, 65, and he at that time Mr. Branson and John Osborne had already developed two oxygenators. They were disc oxygenators primarily, but they always knew that they needed a membrane oxygenator if they wanted perfusion to really be good. Mr. Branson developed the membrane oxygenator along with John Osborne. And when I got there, it was sort of completely finished and was just beginning to be used in the operating room for routine open heart surgery. I mean, that was a big event because these were slightly reusable. All the innards had to be changed. It was a big job to put them together. But from the beginning, they thought that it would have a role in long-term perfusion. And I ended up doing all the animal tests on the long-term perfusion. And long at that time was to do it for 12 hours in dogs and not on calves, but on dogs. At the same time, in the country, the period of getting an oxygenator that could get you through a heart operation had changed, and most centers sort of had a heart-lung machine that was pretty good and would last for a couple hours and didn't automatically kill the patients. But so a lot of work on membranes just kind of disappeared. But there were 4 or 5 people in the country that were still doing it. They were all young people, and they all became friends of mine. People like Ernie Landy and his oxygenator in Houston, particularly Bob Bartlett and Phil Drinker in Boston, Warren Zappel and Cole Paul, also at the MIT, and Pierce had the General Electric. And we used to talk to one another, and it wasn't a whole lot of places to go once you've been doing this in animals. So you just wanted to be sure they didn't have too much hemolysis, didn't clot up, oxygenated blood, inlet and outlets were good. And we started looking for patients to do it. You have to remember at this time, there was no IRBs, FDA, anything like that. It was all done somewhat on your own, with colleagues watching you over your shoulder, that you didn't do anything that was really reckless. But at the beginning, 68, 69, 70, we mainly ended up doing patients with viral pneumonia, and often young people, often in desperate situations. And we would try to get them through the operation. However, viral pneumonias don't get better easily. And those were the main kinds of cases we had. And the way this case that I was successful on arose was pretty interesting. I was good friends with Don Trunke, who was a resident at that time at San Francisco General Hospital, and he knew what I was doing. He had a 30-year-old girl that was a law student who got totally intoxicated, aspirated alcohol and her stomach contents, had terrible ARDS, called me up and he said, "Can you help me?" And I went over and said, "Sure, I think we can help." And we brought all the equipment over, and we were about to do it. And Barry Fairley, who was a great anesthesiologist and a great philosopher and a great teacher, showed up on his weekly rounds for the intensive care unit at San Francisco General Hospital. And he said, "What are you doing?" And we explained what we were doing. And he says, "I'm not sure you should use a device that has never been successful before you've exhausted everything. And you have done all the usual things, but we should try hypothermia. So I said, okay. And Dawn said, okay. So I left. And that night I got a call from a surgeon from Santa Barbara Cottage Hospital who had a trauma case in a 23-year-old boy, multiple fractures in his pelvis, fractured tibia and fibula, and a ruptured descending thoracic aorta just beyond the left subclavian. He took him to the OR, repaired that successfully, but 2 days later, his lungs were really disappearing, couldn't keep him oxygenated. His name was Tom O'Brien. He was trained at the Brigham Hospital, and he knew Bartlett, who was at the Brigham Hospital, and he knew Bob Bartlett had been interested in artificial oxygenators. So he called Bob Bartlett and he says, can you help me? And Bob Bartlett by that time had moved to UC Irvine, but he wasn't completely upset up to be able to do it. So he says, call Don Hill in San Francisco. So Tom O'Brien called me and he told me what he had. I said, I think I can help you. And we got everything moved down there in about 5 hours using Mac airplanes. At that time, Military Air Command were very cooperative. And we moved the whole equipment down there. We watched the patient for 18 more hours, did not get better. He had done absolutely everything, peak, dehydration. So we put the patient on bypass, veno arterial, and for the first 2 days, he didn't do much. On the third day, he started to really turn around. We challenged him by taking him off the ECMO and ultimately decannulated him that day successfully. And he had had mental confusion, a shocked lung, multiple other problems. His kidneys were shutting down. His brain got into trouble, but Tom O'Brien turned out to be a really good intensivist as well as surgeon, and he got him through the next 6 weeks when I returned to San Francisco, and that was the first success. And that changed everything because suddenly we knew it would work.
That was such an amazing story, and I hear that quoted at many, many ECMO conferences, and that photo of that patient
Yes,
that looks like a washing machine surrounding him.
yes, yes.
But what history was made that day? You've been quoted as saying at first everyone died, but we kept working on the technology, and then we had one breakthrough case and everything changed. How did things change then? What happened?
Well, the thing that case illustrated was that the lungs had the capacity to recover. I mean, you could sort of say, why are they going to get better? And because we had never had one that got better. And viral pneumonia was not a great place to begin. Because we used to track these patients. We'd had them on ECMO for 2 weeks. We biopsied them and their lungs just got injured and could not get better and end up with all scar tissue and ultimately wouldn't work. But this was a different entity and trauma did better. And this went on to the next couple of years. We learned more. 2 things. One, Bob Bartlett deserves a lot of credit for introducing pediatrics into ECMO. And he did that. And that's a more mechanical use of them, not always, but he could get successes eventually doing that. And that showed that once again, the lungs can get better. And the thing that was most instructive was that with this starting to being used a lot around the country with mixed results, L'Enfant, who was the head of NIH in the pulmonary division, was afraid everybody in North America was going to do ECMO, and that would have been really expensive. And he says, stop, it's time for a trial. And we got to test this if it really works. And so the trial was set up and carried out and started in 76 and took 3 or 4 years and was a total failure because the treatment groups with and without were essentially the same and they all died, not completely, but practically. And so that really set us back. And the big lesson on that was never take a medical device for an interface until with patients in a clinical trial until you're absolutely sure it's going to work. And this is true in ECMO, but it's even more true with cardiac devices, with LVADs and things like that. You got to be sure that you're going to and can support the patients successfully before you challenge them against the status quo of what's going on at that time. And otherwise, it's a really complete waste of money and time, and often kills the therapy. So we learned more and more about anticoagulation. ACTs came in, we were able to manage it. We learned to manage the ventilators better. All that slowly turned around over the next 15 years. And now people are not afraid to use it. It's being used thousands of times a year. And I won't say we're there, but it certainly has a place in therapy, every day and every week in every big hospital.
Absolutely. There's no question that structural heart therapies have just taken off nationwide. And I think every center is seeing the effects of that. I want to fast forward just a little bit to one of your next firsts. In 1984, you performed the first heart transplant at Pacific Presbyterian Medical Center, our small San Francisco non-university hospital. And that was the first transplant in a non-university setting. What do you remember most about that patient that was our first transplant?
Well, I remember most about what led up to it and why I did it. I was 30 miles away from the most famous transplant center in the world, Stanford, and I was doing a lot of work in LVADs and was able to develop them myself. And I was tied closely to Thoratec, and we were doing large animals and for various periods of time. But I knew it was going to be a long time before we'd be able to put that in place of heart failure. Bridging a person to transplant sounded like a good way to temporarily use it and then go on to transplant. And it wasn't putting too big a challenge on the heart lung machine or on the device. So I decided that we really needed to learn to do transplant. And we already had a good ICU. We had 2 surgeons. We had full-time intensivists. And most importantly, we had a big kidney program with Barry Levine. He was very much in favor of going to hearts, and he could supply all the immunosuppressant technology and ability. We practiced how to do a transplant. I went down to Stanford once to watch one. But there were so many people there, I was like 6 feet away from it and didn't really see much of it. But we practiced in autopsy rooms, etc. And most importantly, a colleague of mine that I knew from Edmonton, a Canadian surgeon, was a fellow at Stanford, Dennis Modray. And he was down there learning transplant, and he came up and helped me do the first transplant. And that was a big help. He assisted me, gave me some good pointers that I wouldn't have otherwise known, particularly in a clinical situation. But anyway, it went very well. The patient was a woman in her early 30s, cardiomyopathy and postpartum cardiomyopathy, as it turns out. And we got her through the operation. She did extremely well. She lived for 3.5 years and unfortunately died because this was 1986, I think somewhere around 86 or 84, no, 84, I think it was. Blood was not being screened for HIV, and she got 1 or 2 units of blood during that operation, and she died with AIDS 3.5 years later. And was very sad, but that's what happened. And we had otherwise had extremely good results. The first 10 patients we did extremely well for transplant.
I remember that time and training for it, and what an exciting time it was to be in this somewhat smaller hospital, non-university, but clearly an academic setting. Then 2 years later came your first bridge to transplant using a VAD. I remember this patient well. I took care of him as a staff nurse. And I also remember that there was news at the local level, and people were calling in offering to donate their hearts. They weren't quite clear on the concept. um, did that case prompt the Today Show interview? I'd like to hear about that interview also from you.
It did because we had been, I would say, quietly doing heart transplants. But that story made a lot of news everywhere and sort of set the stage for being able to do bridge to transplant successfully, and that would change everything. But a lot of people were properly saying, at that time, I was, I think, the first private hospital to do transplants, and we had a big VAD program, and we were doing transplant, but it was mostly a VAD program. And so people were sort of saying, you're 30 miles from the most famous and best transplant place in the world. Why should you, private hospital, non-academic center, be doing that kind of stuff? So I had to respond to that, and I had actually a pretty good answer. I mean, for myself and for my hospital, because we were an academic center, but not a broad one, and we weren't particularly in transplant, but we were in VADS, and we had an animal lab. We had full-time engineers, we had intensive care units, we had a highly trained staff, and we had good immunosuppressive technology, so we could do it. And I knew that there were excess donor hearts available in Northern California. This was before UNOS and delegated ones, because we had a kidney program and we always were giving away hearts. So we knew there was excess hearts available. We knew there were patients that needed transplant that weren't getting it. We knew we had the skills and ability to do it, and we had the support of our hospital. So we thought that it was perfectly appropriate for us to do it. And we were doing research on VADS, and that was the academic standard. So we made a good defense of it. And, soon places all over the country were starting to do that, and more and more private places were doing it. And whenever a private place do it, they always did it with an academic culture. There may be their whole center wasn't academic, but in that area it was.
I
So it was a happy day.
I remember that time, and engineer David Farrar would go on rounds with us, and it was just always educational and a true environment that fostered learning and innovation. And for anybody that's watching this that wants a little bit more of that, we did a video with Jane Reedy and Julie Shin a couple of years back on nursing giants and mechanical support, and we highlight some of these things and have pictures of your program and others, and it was truly a memorable time in mechanical support. Did you think it would go where it has? Has any of this surprised you?
Well, I guess I was a little surprised at the beginning, but after it was well established, I wasn't. And of course, then, there was almost a 20-year lapse between having bridge to transplant and then permanent VADs in place as a long-term therapy. And that took a lot of research, a lot of clinical trials, a lot of FDA, a lot of IRBs, and a lot of teams working together and to get it to that point. So we had to get a big pump and get it smaller. There was a lot to be done. But for bridge, it allowed a lot of people to live that would have otherwise not lived. We learned a
Absolutely.
lot.
Absolutely. I'm going to switch gears here and just bring up a personal story that I recall. Of all these accomplishments we've been talking about, I just want to throw in a case I remember very well. This was a woman in her 30s. She was 8 months pregnant and started having embolic strokes. And it became clear that these were from her valves and she needed to go to the operating room. So you took her to the OR, you replaced or repaired all four of her valves. I think she weighed about 85 pounds, came out of the operating room with a retractor in her chest, was open for a week, Everybody was pretty much ready to give up, but you said no, that we were going to pursue this. And in fact, she did recover. She lived, and I think had all of us in tears when she came back a year later with her baby. So when you think of your contributions and all these things, what pops into your head? Is it patients like this, or is it the research you've done, the landmarks that you've created? What do you think about as you look back on this illustrious career?
Well, I think that you learn to know what is reversible and what is not. In that patient, I mean, I was surprised that we got away with it at the time because I couldn't get the chest closed because her pregnancy was pushing it up, her heart was big, and and I'd done fixed 4 valves, and couldn't even get the chest up. However, you knew a couple things. One, her brain was intact. Two, she was young, and that allows you to have a big advantage. Three, her kidneys were not great, but they were working. And four, her lungs were working enough on a ventilator that we got away with it. So you couldn't say that something is not fixable. And don't forget, her muscle of her heart was fundamentally okay. It was kind of beat up because of valve problem, but it wasn't, there was 100% of her muscle was still there. So I just said, I don't see that there's some signal here that this is not reversible. And it's the same all the time. You sort of ask yourself, these people, can that change? Can that change? And if the answer is categorically no, and of course the biggest one is the brain, because you can always help the heart. You got drugs, valves, pumps, extracorporeal circulation, ECMO, We've got nothing for the brain. If the brain takes a hit, it very often has it forever, and it becomes a limiting factor to an operation. And of course, the lungs are another one. If you get behind on them, it's hard to turn them around. Kidneys, you can carry them for a long time, and you wouldn't turn something off because a kidney isn't working. You can transplant them or you dialyze them. So it's sort of find out, what can I turn around? And if you can turn it around, you should stick with it.
Clearly, time was not the factor that was determining
No.
the outcome. And I'm really grateful for the decisions that you made in that case. You have definitely been on the forefront of cutting edge research throughout your career. And what do you think it takes to do innovative research today?
Today, it's both in some ways easier, in some ways harder. Easier in the fact that there's so many questions and issues that we have that requires new innovation, that there's lots of opportunities to do it, but it takes a much bigger kind of collective effort. However, I would sort of say what it takes in the person. It takes a person that has a curiosity. It takes a person that has imagination to say, how other ways can I fix this? How can I fix this? It's not good enough. Or if it's never been done, is there a way we can find a way to do this? And then the third part is to sort of mix curiosity and imagination together and get a vision of what is possible. This might work, this might work, this might work, et cetera, because you can't try everything. And the most important thing you have to look at is to try to understand the device or therapy interface with the patient and tissues. Is it going to survive that? How can you do that interface? Will it work? Will it work? The fourth part is reach. You have to have reach. And what does that mean? That there's kind of several kinds of research, some who don't require reach. For example, a surgeon can have a great idea about how to do an operation in a little different way. And it's only him and his team that are involved, and he can work it out and do it that way. And it doesn't require a lot of people. Or there is certain kinds of basic research to challenge big issues. And for example, in devices, I would say biomaterials that are blood friendly. You know, here we are, we're 70 years into devices and we still don't have the perfect material. Artificial kidneys, artificial lungs, artificial hearts, certain kinds of brain issue, vascular issue. We need a better blood interface. That will all happen with basic research in a lab, and that is a lab, a team narrowed in there. However, when you start to get into innovation that is broader and is devices and is clinical interface going on, then you often need a broad team. You need hospital support. You need department support. You often need other specialists, engineers, biochemists, computer scientists, etc., that will form a team in order to get to the solution. And that takes money and that takes depth. For example, the original people doing ECMO, the reason we were doing ECMO is that we had oxygenators. And if you don't have the device, you can't do it. And nowadays, if you're interested in applying AI to medicine, you better have a computer scientist and a machine engineer that understands machine learning, or else you're not going to be able to do it. And so you have to have a broader tap. You have to have more disciplines. I must say that I like people that are really smart with PhDs. However, I also have a great like of trainees who arrive on the scene with two disciplines. Best example is you may have done undergraduate in engineering and now you're a doctor. You can't beat that. Or you may have been biotechnology and then took medicine. Or you were a computer scientist and then you took medicine. These are powerful dual disciplines that are really good when you're doing innovative research. And you have to, when you start to this level, you've got to have a lot of support and you got to have money and you got to find that money. Sometimes it's in industry, sometimes it's in grants, sometimes NIH, sometimes the hospital itself has money, but it's much harder. You got to have a team. Hard
You
to do.
Yeah, you have been the epitome of a team player throughout my career, and I'm incredibly grateful for everything that I've learned from you. And I'm super grateful that you were able to give us your time today. We are concluding our interview with you now. This has been wonderful. You are without a doubt a true giant in cardiothoracic surgery, and I thank you so much for your time today and mostly for your outstanding contributions to our specialty. Thank you so much for your time and being here today.
Thank you very much, Joe, for asking me. And for all those innovators out there, I would just have one piece of advice for them. Be sure that you are accountable for the outcomes of your research. You have a duty and a responsibility to make sure that your research does the right thing and society doesn't suffer because of what you're doing. And this involves with AI, and who knows what CRISPR is going to do, and genomics, all those things you have to be more accountable for than I'm seeing today. And this all falls back on the inventors. So thank you very much for being here. I appreciated doing it. I hope somebody learned something.